All right, so I promised in the video that I would do the vital signs exercise that I usually do with my paramedic students. And, it's nothing magical or anything like that. You've probably done something like this in EMT school or the likes, where, you've talked about patients and compensation, decompensation, that kind of stuff. So here's what I'm going to do. I'm going to lay out some vital signs of some patients, and we're just going to kind of talk about that. So let's say there's a motor vehicle accident, right? Or motor vehicle collision. And when you arrive on scene, you have I don't know, you can call it a 42-year-old male. And he is standing outside of the car. He seems pretty rattled and upset. And when you get an initial set of vitals on him, you have a pulse rate of, let's say, 117, okay? You took it for the full minute, so that's how you got 117. And you've got a blood pressure of, I don't know, let's say 140 over 94, okay? And his respiratory rate is approximately 20. So my question at this point, usually to my students is this patient sick or not sick? And the correct answer here is actually, I don't know. I don't know. I don't know if he's sick or not sick. I don't know if this is good or not good. I have no idea at this moment, okay? And I still have to keep an eye on the patient, see what's going on with the patient, see if he's improving, whatever. If we're talking about a few minutes after a motor vehicle accident, I think if I were in a motor vehicle accident, I would be both upset and I would be a little angry as well. So there's always that possibility of having that high heart rate, a little bit of a high blood pressure, and a high respiratory rate. All right, so let's say after about 5 minutes, I take a repeat on him, and his pulse rate is 102. His blood pressure is 134 over 86. And his heart rate, or his respiratory rate, is 18, okay? So then I ask the question usually to my students, is this patient getting better or not? And most of the time they say, he's getting better. Okay, yeah, I agree, I do. I actually think that he's getting a little bit better. Maybe he's calming down, maybe he's feeling a little bit better, maybe he's a little bit more relaxed. We asked him, he's got no pain, nothing like that. So a couple minutes later, maybe, it can be 3 minutes later, I guess. Just before taking a refusal on him, I go ahead and do another set of vital signs, and at this point, his pulse rate is 84, his blood pressure is 130 over 90, and his respiratory rate is 16. So this is a patient, of course, you're looking at him, you're saying, he's fine. And the reason that I know that is because I've got some data here. I've got some data points all the way through, and I've got trending. Trending is obviously a big word in vital signs. So this patient, I've got some trending on him. I know that he's actually getting better and not necessarily getting worse. So let's take another patient. Let's take a 38-year-old female. And she was in a motor vehicle accident. Same thing, MVC. Not the same accident, but she was in an MVC as well, okay? And what I noticed from her is that the initial set of vitals I get on her is pulse rate is 120. Her blood pressure is, let's say, 102 over 60. And some of you may cringe at that, but don't cringe yet. And her respiratory rate is 20, okay? So you look at that, initially maybe you think, okay, maybe that's not so great. Maybe that blood pressure is a little borderline, 102 over 60. But, it's not uncommon for anybody, it doesn't have to be male or female, but it's not uncommon for people to have blood pressure that's a little low. It's kind of okay. It's not necessarily a big deal. Maybe we're not necessarily freaking out about this right now. Maybe we're looking at her skin temp and condition and making some decisions based on that. And right now, the skin temp and condition, she looks normal, okay? So as time goes on, what I notice is after about 5 minutes, okay, 5 minutes, Her pulse rate is about the same. Her blood pressure is close to the same, 100 over 60. Okay? And her respiratory rate is 24. So the question you ask yourself here is this patient getting better? Is this patient getting worse? Is this a patient I need to concern myself with? Yeah, and I'm willing to bet most of you would say, yeah, I'm a little concerned about this patient. She still has a heart rate sustained over 120. She has a blood pressure that is still kind of borderline. And she has a respiratory rate that at this point is pretty elevated. That's not necessarily good. And I would be concerned that this patient is potentially in she's potentially in a compensated shock. I think there's a very good possibility here that this patient is in compensated shock. Okay? So now after, let's say, same amount of time there, right, 3 minutes later, you take another set of vital signs on her, and she's now at 134. Okay, immediately that tips my brain off to say, okay, something's wrong, something's going on here. Her respiratory rate is about the same at 24, but her blood pressure is, let's say, 90 over 48. Okay, all of you at this point, you know, the alarm bells have gone off. Ding, 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 ding. Yeah, this patient is in shock. But at this point, what I would want to know is she beginning into decompensated shock? And the answer to that is probably. Generally, what I look at for that dividing line between my compensated shock and my decompensated shock is right here. When the blood pressure starts to make that drastic of a change, and you know, you may look at it and go, well, that's not all that drastic. Well, it's drastic enough. And when I see a blood pressure making that change, if everything else was remaining the same, or let's say the heart rate was kind of coming down a little bit or something like that, then maybe I wouldn't be quite as alarmed about this blood pressure. Maybe I'd just ask her, hey, is that a normal blood pressure for you to be a little low? And she's like, yeah, I'm fine, you know. But then what I also notice along with this is that her skin temp and condition has now changed a little bit. She's gotten a little cool, and she's gotten just a little pale. This is a patient then I would immediately say she is starting into decompensated shock, and I need to make sure that I get this patient treated and get her to definitive care. Okay? So, you know, that, again, there's that alarm bell for me, right? That's definitely a big thing for me. So then the other patient that I usually give, let's say this is let's say a 68-year-old male. And let's say this time it was a fall. And we'll say it was a ground level fall. He fell. You know, he has a pretty obvious hip fracture, and you know, you can tell it's angulated, or it's you know, it's kind of turned inward. I mean, it's pretty definite. This guy has a hip fracture. So my initial vital signs on him are, let's say, a pulse rate of 50, a blood pressure of 120 over 74, and let's say a respiratory rate of 20. So does this raise a little suspicion to you? Does this seem a little odd, a little weird, besides the fact that I decided to write in red on this one? I don't know why, but I did. So you look at this and you say, well, wait a second. The blood pressure seems pretty good. That's I like that. 120 over 74, that's pretty good. Respiratory rate may be a little elevated, but what in the world is going on with that pulse rate? And some of you may actually be thinking, well, maybe it's spinal shock. Maybe he's got some sort of damage to his spine, and that's what's causing him to have this low heart rate. And although that is a possibility, I think there's something here that may be a little bit more of a possibility. And I'll pause for a second, let you think about that. What do you think it might be? And the answer to me, what I'm thinking is, this is medication induced. this is medication induced. That's what I'm thinking. I'm thinking this guy's probably on beta blockers or something like that. Maybe he's got hypertension, and so he's on beta blockers, and maybe this heart rate for him is kind of normal. Now, I would be concerned, obviously, if his normal blood pressure, let's say his normal blood pressure is like 168 over like 110, then I would consider this patient to be hypotensive and potentially going into decompensated shock. That I would really concern myself with. But no, that's not exactly, that is not what is happening here. We can just erase that off of there. What we actually have going on is this patient is most likely on some form of medication that's causing his heart rate to stay down. Well, obviously, this can be a concern in a bad trauma, right? So if this elderly patient, he's 68, he's just on that edge of elderly, but this elderly patient, if his heart rate remains at that low level and he becomes hypovolemic, right? And we remember this. There we go. Say it again. Cardiac output equals stroke volume times heart rate. Well, the medication is acting on his stroke volume, right? The medication is acting on that stroke volume. If it's a beta blocker or something like that. If it's an ACE inhibitor, it may be a little different. But let's say it's probably a beta blocker. And so, there I go. Oh, sorry. See, I'm sure some of you at home are like screaming at me. No, you're not right. No, it's acting on his heart rate. Yes, of course it is. My mistake. Sorry about that. It's acting on his heart rate, right? The medication induced is acting on the heart rate, and probably a little bit of action on the stroke volume as well. But you're getting mainly the action on those beta blockers is going to the heart rate. Okay, so if I have a decrease in that heart rate and I'm losing blood, right? So the heart rate is going down, and I'm also losing blood. So I'm losing my stroke volume. This is one of the reasons that some of my elderly patients may actually decompensate quicker, because they're taking medications that help to keep that heart rate down, and that medication is making it a little harder for their body to compensate. Okay? So you may actually see that some of these elderly patients will drop quicker, because they are taking medications that are affecting their heart rate. So and ergo affecting cardiac output. Okay. So let's go to another patient. Let's go away from the elderly patient, and let's say this is a healthy 18-year-old male. Okay. So we have an 18-year-old male, and he was injured in a I don't know. Let's make it a motor vehicle accident again. MVC seems to be the thing. So he was injured in a motor vehicle accident. We have a relatively healthy 18-year-old male. Okay, and what I notice out of him when I look at his vital signs is I've got a heart rate of 140, which should immediately in your mind tip you off that something could be going on here, right? And I've got a blood pressure of 126 over 84, okay? And I've got a respiratory rate of, say, 16, okay? So everything here, if I look at just the blood pressure and the respiratory rate, I'm relatively happy with just the blood pressure and the respiratory rate. That heart rate does concern me. Now the question has to be, is that heart rate sustained? And at 5 minutes, you notice that his heart rate is 142, so there you go. It's a sustained heart rate, 120 over 82, and the respiratory rate has stayed the same. So is this patient potentially in shock? And the answer is yes. Yes, this patient is potentially in shock, and he is compensating. Now, this is a healthy young man, and this healthy young man is compensating relatively well. But eventually, he's not going to be able to compensate, or potentially, I should say, not going to be able to compensate. And after that 3-minute time limit, what I start to see now is his heart rate is, let's say 84, okay? His blood pressure. Now, first you look at that, you go, wait, heart rate 84, that's good. That's good. He's calmed down. Everything's okay now. But now watch his blood pressure. We got 90 over 60, and the respiratory rate is now at 24. Right, exactly. So the problem that we run into here now, of course, is that this patient is definitely decompensating, and he is decompensated quickly, okay? So ways to help you watch for decompensated shock. I think number one is just look at your patient, right? Look at your patient. Take your vital signs, obviously, but look at your patient. Cool, pale, diaphoretic, those kind of things. Those can sometimes tip you off. Now, in your neurogenic patients, it's a little harder because they usually don't look cool, pale, and diaphoretic. They usually look flushed. So they usually look kind of red and probably dry, to be honest. So, you look for those patients, you look at them. You just say, hey, this guy looks like he's not doing well. But the other thing that you can look at, and probably one of my favorites to look at, is end-tidal CO2. So the thing with end-tidal CO2 is that it can really tip you off that your trauma patient is in trouble, okay? It can really give you that tip off because if your patient is hemorrhaging, right? They're going to be on, remember when we talked about VQ mismatch, right? Ventilation perfusion mismatch. If they're hemorrhaging and we're not seeing it, right? It's internal hemorrhage. Then this patient is on the Q side, right? They're on the perfusion side. And that means that CO2 leaving, CO2 getting to the end-tidal CO2 monitor is going to decrease. Okay, so the end-tidal, the CO2 getting to the actual, spoon or pins, whatever you want to call those little things, is going to decrease. All right, I know it seems kind of weird because you think, well, wait a minute. If perfusion is down, then that means that your patient is probably going to be acidotic, and so wouldn't their end-tidal CO2 go up? And the answer is no, because it's not a ventilation problem. It's a perfusion problem. Now, eventually, if we're talking about crush injury or something like that, then yes, obviously that's true. But if we're talking about something like hemorrhage, we're talking about more of a perfusion problem, okay? And so when that end-tidal CO2 is dropping, that's a sign that your trauma patient is in a whole lot of trouble. If you look up studies on trauma patients and end-tidal CO2 results, what you generally find is that the patients that presented to the emergency department, or the patients that even were eventually admitted to the ICU with a low end-tidal CO2, a lower ETCO2, were much more likely to have poor outcomes or to not make it out of the emergency department or the ICU, to die, okay? They were more likely, the mortality rate increased with them over the people who came in with either a normal end-tidal CO2 or only slightly low end-tidal CO2. So maybe, those patients that were in the 32 range or something like that. I don't have the exact numbers in front of me, but what was found in most of these studies is that the lower the end-tidal CO2, the greater the chance of mortality. What that also tells me is that if that end-tidal CO2 remains low and stays low, that cellular respiration is breaking down. And so now the body is not producing as much carbon dioxide, essentially, getting the waste product out. And so that means that the kidneys are going to start to fail. Eventually, the liver will probably start to fail. The kidneys almost always go first. The liver will start to fail. the heart will probably start to see arrhythmias, and then the patient will die. So, so end-tidal CO2 can be a good predictor. And again, I say good predictor. It's not a great predictor. It's not the best predictor. But you can look at end-tidal CO2 and get some idea as to whether or not that patient is currently sick, currently sicker than maybe they look. Now, as far as long term, there's still a few studies on that that's showing that end-tidal CO2 is not one of the best predictors in there, but I think there's still more to come. End-tidal CO2, as far as looking at short-term, ED, maybe even ICU, again, that's a little bit more long-term, those numbers show that the lower the end-tidal CO2, the higher the mortality for the patient. So, so that's kind of where we're speaking. We're speaking about things that are more short-term. So there you go. There's a little end-tidal CO2 for you, a little ventilation perfusion mismatch. And that's all I've got for this one.